So my name is Erin Simmon. I'm a nurse practitioner at Norton Cancer Institute in Louisville, Kentucky. I work in the outpatient setting with adult sickle cell patients. I'm going to present a case of an adult patient with new onset seizures and concern for silent infarcts. This patient is a 41-year-old female with sickle cell hemoglobin SS disease with retained F. She also has history of ABN. She is status post hip replacement. She has history of microalbuminuria, and then questionable pulmonary hypertension. She had one echo with an elevated jet velocity, but her last one was normal. She also has frequent complaints of pain crisis and chronic pain. She is on about 90, she takes 90 Percocet a month. And she does visit the infusion center about 1 to 2 times a month with complaints of pain crisis. She also has considerable anxiety, and she meets with our LCSW for counseling. She experienced a new onset seizure in June of 2022. She has just experienced her third seizure. March of this year, she experienced her third seizure. When she's has these seizures, they're pretty severe, like full body type convulsions. And her Keppra keeps being increased. So she's now on 1,500 milligrams of extended release Keppra at night. Neurology is managing this. She had her second seizure in July of 2023, around the time I first met her. And she did admit to missing a dose of medication at that time, so they just increased her Keppra. And then her initial seizure she experienced actually a few weeks after having her hip replacement. At that time, she had her hip replaced. Her hemoglobin was 8.4 on the day of surgery. I'm not sure why she wasn't transfused to get her greater than 10, but I think there was maybe a little bit of a knowledge gap with the last APP who was caring for her and didn't realize that that was like guidelines. So she didn't get transfused prior, had the surgery, and then her MRI, when she presented with a seizure, showed no overt stroke, no hemorrhage, but small preventricular white matter changes involving the frontal and parietal lobes. And then the read said this looked like a demyelinating process, such as multiple sclerosis is how they described it. So then neurology, when they saw that, they did a CT angiogram of the head and neck, and then it showed no evidence of stenosis, dissection, or aneurysm, so no concern for overt stroke. And then at that time, I don't think there was much discussion about like considering chronic transfusion. So when I met her, she wasn't really on anything for management of her sickle cell. I started talking to her about hydrea. She was opposed to that. So she then was willing to try Oxbryta. So she's been on Oxbryta since August of 2023. She has a hyperhemolysasizer, and it has improved her baseline hemoglobin and bilirubin being on the Oxbryta. And then when I started kind of questioning, was her MRI from 2022 a sign of silent infarct, I was able to convince her to then get on hydrea. So she just initiated hydrea in March of this year. She's on vitamin D for vitamin D deficiency, vitamin B12 for vitamin B12 deficiency, Keppra, and then her pain medication, Miralax, Paracolase, and then Buspar for anxiety. These are her last labs. And there's no concern for misuse of opioids, normal tox screens, normal vitals. So basically, when I was looking back at her MRI from 2022, I was concerned that maybe this was a sign of a silent infarct. Just looking at ASH guidelines and their definition for a silent infarct, on the read, it doesn't really say how large these abnormalities are, but to me, they sound a little bit concerning. So I did talk to the patient recently about ordering a follow-up MRI just to see if there's progression based on the ASH guidelines of monitoring this every 12 to 24 months if there's concern for an infarct. And then I reached out to the neurology APP that's managing this patient's seizures, and I don't think she really knew what to look for in the way of like infarcts. Silent infarcts are concerned for that with a sickle cell patient, but she did reach out to a neurologist who said, there can be these vascular changes with sickle cell. So he recommended I send her to a neurologist that has specialty in vascular neurology. So I have referred the patient. And then we weren't doing routine MOCA screening on all of our patients, but I actually presented a different case at a support APP echo, and one of the John Hopkins APPs recommended that that's something that we should be doing on all of our patients with sickle cell. They do it yearly for their patients. So we are going to screen this patient with a MOCA to see if there's any cognitive impairment. And then the patient is now taking Hydrea plus Oxbryta. I've had discussions with, all of our automated exchange takes place in our pediatric space. So I've had discussions with Dr. Raj, with our pediatric team about whether or not this patient would be a candidate for exchange transfusion. I'm questioning, do we need to put her on some sort of a chronic exchange type plan to prevent overt stroke, based on ASH guidelines, which talk about, if there's concern for silent infarct, that you should escalate therapy. So Dr. Raj said to present this patient in this echo to kind of get everyone's input on what we should do, because this patient is seeing improvement in their labs with Oxbryta. So her baseline hemoglobin before was 7 and her Billy was like 5 to 7. Now she's her hemoglobin is more like 8 or 9. Her Billy's 3 to 4. But I mean, there's no research to really say that Oxbryta is going to prevent her from having a stroke. That's just one of my questions moving forward. What would you do with this patient? Would you start doing simple transfusion monthly on her? Would you consider automated transfusion? And then just, do you at your center do cognitive screening on patients? Do you do it yearly? And then just looking at ASH guidelines, it's saying that you should perform a one-time MRI on all adult patients for screening purposes. But my question is, at what age do you do that? Patients with SS and S beta thal 0. And then I have several patients that they've had a TIA or they've had a overt stroke as a young adult, and then they weren't really like put on a chronic transfusion type plan afterwards. So now, for example, I have a patient that's maybe like 30, but at 22, she had a stroke. Do I put her on a chronic transfusion plan now? Do I circle around and say, hey, we need to start this? And then how do you weigh just risk of some of the risk of chronic transfusion with potential for alloimmunization and iron overload versus the reduced risk of stroke with chronic transfusion?
I'm going to stop you so we can start answering some of your questions.
Okay.
And I'll start with a couple of things. So the first is, neurology is not usually who I ask to give the to measure. So you want to call your neuroradiologist. So the radiologist is who can measure those lesions for you. They do sound like there's some small silent infarcts. It's pretty consistent with what we see. It's more than one. That's several perivascular. It's about Very, very common, but you can see how big they are. So that's who you ask for that. The second thing that you should consider is that she had that original MRI in June, so you could definitely repeat the MRI now and see if it looks different because she's been on voxelotor for a year. And I think that may give you some answers, at least in the beginning, to some of your questions. In terms of the MRI screening, as part of the Alliance screening recommendations that we're working on publishing, the decision was made, the consensus recommendation was made that you get an MRI as soon as, but not within a year of last MRI of establishing adult care. So we wanted to put some context around what those ASH guidelines say, because just saying one time, sometime is kind of difficult. And that then if something was seen, that you should continue to follow MRIs every 12 to 24 months if it's going to change your management. And so that is some guidance there that I think you'll be able to see soon. And then I think in terms of whether you use transfusions for silent infarcts, and we can let everybody else weigh in, I think it's a very heterogeneous decision is what I think you're going to hear people say. The SIT trial suggested it might be effective. But I personally, anybody who's had an overt stroke, I absolutely recommend chronic transfusions because their risk of a second ischemic or second stroke is upwards of 50% in adulthood without it.
Okay.
Other thoughts? Those are mine.
What about a TIA? Would you?
So I personally would do an MRI and MRA and make sure of what you see. If you see some vascular stenosis, basically we know, right, that there's an increased risk of stroke and that we want to do everything we can to prevent primary and secondary stroke. So if you saw severe vasculopathy even without stroke, yes, then I would. If I didn't, I would probably not. And I'm also curious, you didn't mention whether this patient had an EEG and whether they found an epileptic focus.
I don't think that I know she's had an EEG and I don't think that they did. I will double check on that though.
Julie, while she looks at that data, what percentage of your patients, adults, have silent brain infarcts, you think? And that's about 30%? Is that a big estimate, or, you know?
That's probably about accurate in our SS or S beta 0 patients.
That means, and you're saying in your own practice, you're not managing them homogeneously. It's like a lot of heterogeneous ways you do things.
We have conversations. So anybody who we identify as silent infarct, we sit down and talk to them and discuss, you know, do you want to do hydroxyurea? Do you want to do transfusion? What's going to be best for you? And so it's not homogeneous because it's very patient centric. Some individuals absolutely decide they want to be on transfusion. Some say they don't. Many are on hydroxyurea, and we continue to monitor them and make sure that the infarcts don't grow or they don't develop new ones. And then if they do, we go back and have that conversation again.
What percentage you think start transfusion from the get-go, or once they have progression on hydroxyurea or Oxbryta, then you would offer transfusion? Or
I don't use Oxbryta at all in this scenario. I actually think it's risky, but that's my own opinion. So that's not an issue there for me, but I would have to look at our data. I would say most adults who otherwise are well are not that excited about starting transfusion, but are often willing to start hydroxyurea even if they hadn't before.
yeah, so for decision making for our patient, it's reasonable to continue with the current management, because the question was for us to do the exchange on the pediatric side for this patient. So I'm thinking, like you said, repeat the MRI and then see if there's any improvement or stability. And we can not rock the boat, I guess, if things are stable, and use transfusion.
I mean, I think that's definitely something to do. I would definitely make sure they've had an EEG, and if not, that needs to be done. I don't know if these were witnessed events or not witnessed events, or making sure they're real seizures, not pseudo seizures, right? All of those things I think are also really important. I'm not clear that the seizures and the goobers on MRI are related. So I think there's a lot of questions still to answer. That would be my thoughts, but there are other adult providers on here. Don't make me call on you because I will.
This is Ophelia. I have a question because I actually started the meeting a little bit late. Did the patient have a TIA or not?
No, she's just had, they pretty significant seizures, like they're described as convulsions that have been witnessed by her husband. I mean, one time she fell out of bed and in the middle of the seizure, or this
And
was.
that's when you did the MRI and you saw the silent infarct.
Right, because of
Okay,
the seizure.
okay. Right, but maybe the silent infarct was done, what happened a long time ago, right? I mean, we don't know that.
Right. It doesn't sound like from the description that she had up there that it was an acute anything. It sounds chronic, and that's why I said I think it's probably true and unrelated.
Right, and then the MRI was negative?
Yes,
Right. It had these questionable ditzels. That's what I call them. It's a very scientific word.
Oh, so there were some stenosis by MRI?
Why don't you put the MRI report back up, Erin?
okay.
Yeah, I mean, if there was, from my personal way, I mean, I am obviously a pediatric hematologist. My personal thing is I don't treat with transfusion for silent infarct because I will be treating 20% of the population. But if there is MRA stenosis, especially severe, then I will treat with transfusion. Otherwise, I treat with hydroxyurea.
So that's
Of
what.
course, she have to be on the anti-seizure medication, of course.
Yeah, so it sounds like small periventricular white matter, subcortical white matter, T2 hyperintensities. I mean, certainly sounds like a silent, multiple silent infarcts. But
Is there, if I may, is there any way to sort of risk stratify that? Like, we know that certain patients are, depending on their hemoglobin and other factors, are more likely to have more serious sickle cell complications. Does that factor in at all to the decision? No, it's just whether they want to or don't want to be on something.
I think that we are not good enough to know the answers, hence the reason we need to follow these longitudinal databases, right? I mean, I think we have some things that are predictive, and I think like what Dr. Alvarez said, if you saw vascular stenosis, we would certainly say that would be an increased risk. But in the setting without vascular stenosis, I don't think that we have any good answers. The other thing I didn't hear about is whether she has hypertension.
She does not. She has some protein in her urine, but her blood pressure is too low to even put her on an ACE or an ARB because she's like 110/50.
Oh, I'd put her on an ARB.
But still,
yeah, I would hesitate. We just watch closely and start on the lowest dose.
okay.
What about cardiac? Can these events be embolic from the heart? Does it have a PDA or a PFO? That is, how we look into the heart and see whether this is embolic.
No, I don't think that there has been. Well, she's had an echo would show that, so there's been no evidence of that. No.
Okay, so the cardiologist doesn't have an opinion as to whether these seizures were related to a shower of emboli or something like that would happen acutely. All right.
In the cases I've seen of like fat emboli syndrome, they're not this confined to the frontal and parietal lobes, which this is, so, if they'd had a history of multi-organ failure, that's how, to get this many hyperintensities, usually it's like a fat embolism syndrome, at least in my experience.
Yeah, the two patients of fat embolism I've had, they've been extremely sick patients, I was rounding.
Oh yeah, it's not subtle.
Very distinctly. I just finished the rounds, got out of the patient's room and went to a different patient's room, and the nurse pulled me out. It was acute respiratory and neurologic deterioration that happened so dramatically in both patients in that context. And one survived after ECMO, the one did not, so it's pretty dramatic. It's not.
We see about one a month. We see them a lot in the adult world.
And they all have severe presentations.
Most survive. at least in our hospital. I've certainly done my fair share of med mal cases on the ones that don't, but that's all I was saying in that regard was that a simple embolic event wouldn't look like this. This would have to be a dramatic embolic event from what it sounds like, where they say, you know, multiple areas of concern. That's all I was suggesting. It didn't sound like an embolic event to me.
Will aspirin be helpful? Will those
Doubtfully.
aspirin?
We've never proven aspirin's helpful in anything in sickle cell.
For stroke prevention, it's used in neurologists. I recommend it a lot, you know,
But in sickle,
for
we've
stroke
never proven
prevention.
that it does anything.
Yeah, I use it sometimes.
Make sure you enroll her onto Granddad. That's why we have to have a registry, right? We have to understand what we're doing and what the impact is. So,
In the last question Erin had is about the hemoglobin of 10. Is that pretty strong? 100% of the time you guys do it for patients going for surgery? I mean, we do it on pediatrics, but on adult side, it was a hemoglobin of 8.4 on the day of surgery. So any comments on that?
we always do a pre-op transfusion for a hip replacement. We don't necessarily target, I would say we target 9 to 10, but often use manual exchanges as well. But yes, we always do a pre-op transfusion.
Cutoff of anesthesia time, like for procedures, like procedures longer than an hour that
We use longer than an hour or significant abdominal discomfort usually are our main reasons, yeah. But certainly a hip arthroscopy. Andrew, Dr. O'Brien.
I mean, I think the other question here, though, is that if there's no other clear etiology for these seizures, I think it's also conceivable that there's some sort of perfusional deficit that's causing neurologic dysfunction without necessarily causing sort of ischemia to the point of tissue death that you're going to necessarily see on MRI. So, right, I mean, even if this is a perfusion issue that's not causing true stroke, that's going to show up on imaging, then I don't know that that necessarily disproves that suboptimal perfusion is not triggering seizure activity. I don't think there's any definitive data to suggest that chronic exchange is going to help this, but I don't think it's an unreasonable trial, right? And if that corrects whatever perfusion deficit is potentially triggering these seizure activities, when things get better, I think that's potentially a reason to continue, right? Even in the absence of true infarct. I don't know that that proves that the seizures are not, the absence of a true infarct necessarily proves they're not perfusion related in some degree. I don't know if that made sense, but.
I think it's a really good question, but it's why I'd start with asking, was an EEG done? And if it was negative, they usually, at least in my experience, will do a sleep-deprived EEG next. So I think those, yeah, I mean, I certainly think that's a definite question too.
And it's Toby from UMC Jackson. Just wanted to ask, were there any Keppra levels run on the 2 occasions the patient had the seizure?
No, I don't think so.
Because if the Keppra levels were low, then you could say there was a problem with non-compliance.
I know they just asked about compliance and she did miss a dose with the second seizure. She admitted to that, but she said she had not missed doses with the third.
It is a good question though, and I don't know that we ask the question. I have to look back in Granddad about seizure history because I don't think we ask about seizures, but Andrew, going back to your comment, we do have a couple of adults with relatively recently diagnosed epilepsy, who have a true, you know, epileptic focus of sorts, but they are diagnosed as adults. And I don't know if we have attempted to measure perfusion. One of them had a clear new onset small ischemic infarct, but I don't, not all of them. So it's an interesting question about perfusion.
This is I'm Ayun from Mobile. I just have a statement about a teenager who we transfused for 3 years based on the SIT trial for a silent stroke, and when the repeat MRs were all good, we just stopped. I just want to emphasize that the SIT trial only kind of told us about 3 years. So, lifelong or whatever, that decision, cannot be justified. But, we did that, and we emphasized, hydroxyurea, follow-up, after that. But if you look at the ASH guidelines, there's no recommendation except that you infer that, silent strokes are, up to 59%, in adults, and you need to put them on transfusion. And there's no endpoint to that. Yeah, but actually, the SIT trial was only for 3 years.
Yep. Dr. G.
Hi, everybody. Beatrice G from Atlanta. So I agree with Dr. Alvarez. The combination of silent infarcts with some cerebral artery stenosis is a higher risk factor for getting overt stroke, but your patient doesn't have it yet. Putting someone on chronic transfusions for kind of small findings alone is not going to be, it potentially is going to harm her more than help her, because we don't exactly know if the two problems are related. It would be interesting to know if she had any cognitive deficits as a younger person, and that might suggest that maybe the silent infarcts were symptomatic in some way. Some suggestions about the seizures is maybe tox screen. These might be drug related. Like some of the cannabinoids are pretty potent and can cause neurologic symptoms as well. And then there is there's a version of MRI that's called a perfusion MRI to kind of see if there are areas that have lower blood flow delivered.
All great points, but one thing to also consider that even healthy individuals, as they age, they can develop white matter intensity. So, they are really confound the picture here. How do we sort it out? I think more clarity is needed into which are the patients we will offer exchange transfusion, what are the risk factors? I think that is very important to clearly lay out. Otherwise, we are just over-treating probably patients who don't need it.
I think it's hard to say. And I think we don't know. We have to acknowledge what we don't know. We don't know that we're over-treating. We don't know that we're under-treating. We just still have a huge knowledge deficit that we need to, I think, continue to improve upon. To me, that's the biggest take home is, Erin, there's no right answer here for you. Other than I definitely think I would explore getting the size of the lesions. I'd go ahead and repeat a scan, and I'd find out what your neurology colleagues did to work her up. Those would be my thoughts. And I do get a good alcohol assessment as well as a tox screen, as Dr. G suggested.
Yeah, I agree. I mean, my comment was predicated on the assumption that there was no other apparent etiology. I think if it's been thoroughly evaluated and there's really no other explanation, I think sickle cell related perfusion defects that are not severe enough to cause imaging changes are still potentially causative, but I think you need to be very thorough in looking for other things first. You meaning the neurology team.
Totally agree. All right. Well, that was a great case and really great discussion, and, just continues to, unfortunately, tell us a little more of what we don't know than what we do know. But as the way it is with sickle cell disease, moving forward, we are going to talk about Parvovirus 19 with Dr. G, who earned her MD from Tufts University, completed pediatric residency at Boston Children's, Peds Hemonc Fellowship at the Farber. She was on faculty at Morehouse and then joined Emory Pediatric Institute in the fall of 2019. She's done all kinds of amazing research and is now the director of the sickle cell disease program at the Children's Hospital of Atlanta, if I am not incorrect in that. Dr. G, it is all you.
That is all correct. Thank you very much, Dr. Cantor. So the reason I brought up this particular topic is we've been seeing it quite a lot here in Atlanta. It's 5 cases in 4 months, but it seems like a lot more than in the past. So I just wanted to share with you some of the different things that parvovirus can do to our patients. Let's see, forward. Can everybody see my screen before I continue?
Yes, ma'am.
Okay, so first to review, my objectives are to first review parvovirus B19 infection in healthy people, and then discuss aplastic crisis, one of the better known complications in people with sickle cell disease, and then some other types of problems that parvovirus B19 can cause in people with sickle cell. So parvovirus B19 is different from dog parvovirus. I didn't have a chance to look that up, but it is also known as fifth disease, which only when researching this talk, I realized is the fifth in the list of historical classifications of common skin rashes. So there's a list of 6, and this is the 5th one. And the other ones were like roseola, rubella, et cetera. So, and it's also very hard to find a picture of the flap cheek rash in a dark skinned person. Almost all the photos were very fair skinned people. And so on the top picture, we see the red rash on a fair skinned person, and a similar, the same illness, the rash on a darker skinned child, but it is kind of papular. It's a little bit raised, it is red. These are single stranded DNA viruses. And it's common in late winter, spring, and early summer. There can be minor outbreaks every 3 or 4 years, and I think we're having one here in the Atlanta area. The main symptoms are fever, headache, cough, sore throat, and then the rash. And the other symptoms look a lot like a lot of other things that people can get these days. So it's really easy to, just kind of get it in the mix of regular viral illnesses. So the slap cheek rash appears within a few days of the initial symptoms, more often seen in children. I actually haven't seen this rash too often in the children with sickle cell disease. There can be a secondary rash, which comes about a week later, and it can be on the rest of the body, chest, back, buttocks, arms, or legs. It can be very itchy. And then there can be joint pain and joint swelling. And joint pain and swelling is more common in adult women and can last 1 to 3 weeks. By the time most of us reach adulthood, we have, the majority have had parvovirus infection and are immune. So then why is it bad for our patients? It's because the parvovirus B19 enters human erythroid progenitor cells, some of the early stages, pronormoblasts and normoblasts, through something called the P blood antigen receptor. Other cells that have the P antigen include neutrophils and fetal myocardial cells. So they're not the so red cells are not the only cells that can become infected. Once the cells are infected by this virus, there's rapid replication and it kills the host cells. And in the case of erythroid progenitors, then the cells are dead and the red cell production will stop. And that's why the patients get low hemoglobins. Even healthy children have reductions in hemoglobin about 1 gram per deciliter. But if you start with a hemoglobin of 12, you barely notice it. Whereas if you are one of our patients and you start with a hemoglobin of 6, you will notice it. People with hemoglobinopathies or hemolytic anemias may have a drop of 2 to 6 grams per deciliter, and that's due to having more erythroid progenitors that the virus can infect. So you have a higher viral load. If this happens to a fetus, when a mother is in the 1st to 2nd trimester of pregnancy, it can cause miscarriage due to hydrops fetalis, but that's only reported in about 2 to 5% of pregnancies that encounter parvovirus, probably because many of the moms are immune. All right, so here's a recent case of aplastic crisis. Many of you, I'm sure, have seen this. Sorry for the choppy pasting, copy and pasting of some data in the table to the right, and we'll discuss that in a minute. So very recently, a 10-year-old girl with hemoglobin SS presented with fevers for the past week, abdominal pain, vomiting, and low oral intake. She was definitely pale and lethargic. When they finally drew her blood several times because they didn't believe the results, her hemoglobin was actually 2 grams per deciliter. Her retics were very low, 0.4%, and her absolute retic count was about 2,000. Her platelets and white count were normal. She was immediately given the quickest red cell transfusion we could get. I was hung, and she was immediately transferred to the ICU. In total, she received 30 mils per kilo of red cells, had a final hemoglobin of 8.5 after 5 days, and her hemoglobin A was up to 95%. So basically her entire body's red cells were replaced with transfused blood. Her quantitative parvovirus B19 was extremely high, 10 to the 10th units per mil. So this is the kind of an extreme version of the common presentation of aplastic crisis. And if I were looking at you and asked everybody to raise their hand, I'm sure that some people have seen this before. Dr. Kim Smith-Whitley wrote an article in Blood in 2004 describing the CHOP experience. And what she showed was, on average, the median lowest hemoglobin was 4.8. The median lowest for tick count was less than 1%. And the change in hemoglobin on average was 4%, but people who had hemoglobin SC definitely had a larger drop because they were able to tolerate a larger drop because they started with a higher hemoglobin. So this, our patient's degree, her baseline hemoglobin was like 7, so she did drop 5 grams. She did stay home a little long. She had fevers, like it says, for about a week. The mother said they were low grade, so she didn't think it was absolutely necessary to bring her to the hospital. She said they were always under 101. But together with the vomiting and low oral intake, she ended up being quite sick. One thing I didn't add to this slide was that she also had acute kidney injury due to probably shock for several days because her initial creatinine was 3.4. That has corrected to some degree. Not quite back to normal yet. So any comments on this particular presentation or case? I just like to pick the worst I've ever seen. All right, here's a slightly different scenario. So this young man, 14-year-old boy in 2001, so this is a older situation. He had hemoglobin SS and with parvovirus aplastic crisis, and we treated it with blood transfusions. And it looked like he was improved. Over the next few months, he then developed generalized edema and was found to have low albumin, and it turned out to be in his kidney, in his urine. So he had nephrotic syndrome with extreme protein loss. Over the next year, it progressed, and he ended up having end-stage renal disease and required dialysis. So this is, I've seen this once in the last 25 to 30 years, but it turns out that parvovirus can cause a number of kidney issues. So in this list, this is kind of parvovirus B19 kind of in all comers. So the list includes aplastic crisis in those receiving dialysis and those who have had renal transplant, pure red cell aplasia in renal allograft recipients. But among people with sickle cell disease, the common ones appear to be this focal segmental glomerulosclerosis and maybe the proliferative glomerulonephritis. But it's not uncommon to, or it's not unheard of, let's say, to develop kidney disease after parvovirus. So has anybody seen this type of complication of parvovirus?
It's hard to sort it out if they already had underlying kidney disease and then add parvovirus on top of it, because it can last like 2 weeks or so. It's hard to sort out. It came to recognition because of parvovirus. It's sort of hard to sort it out.
Oh yeah, you're saying maybe the patient had underlying kidney disease beforehand.
Yes.
And then you find that you kind of notice it after they have parvovirus. I guess that's possible. Yeah. But I think many of us are kind of screening for kidney disease kind of often. The urine albumin creatinines, urinalyses, probably about once a year, that type of thing. So.
And it sounds like in him, it was fairly acute. Like he noted swelling where he hadn't, and you'd just seen him the month prior when he got transfused. Yes,
right. So we knew he didn't have it all. He didn't have kidney disease when he had parvovirus. And then he basically developed this, the anasarca, edema everywhere and had the low albumin. And this was 20 something years ago. So we were doing albumin and Lasix infusions and all of that before, and then finally it was kind of like, well, that's just going on too long and we have to do it too many times. So then he got transferred to the kidney center
Interesting.
for treatment. Yeah. Okay, so that's a different one. So it's the reason I bring these up is mostly because they all start with an aplastic crisis, but sometimes the parvovirus problem comes afterwards and may not go away. All right, case 3, we have another 14-year-old. He has hemoglobin SC with a baseline hemoglobin of 13. He presents with acute splenic sequestration. So with a fever, and his spleen is down 10 centimeters. He's never had splenic sequestration before. His hemoglobin drops to 8.7, platelets 90,000. The retics, again, less than 1%, and his absolute retic count is about 1.9 thousand. And what we often have to kind of point out to our residents, like, okay, just because they have sickle cell disease doesn't mean that a hemoglobin of 8.7 is good for them, especially if your baseline is 11 or above. So we try to point out that they need to take those things really seriously. It's not just, oh, that's not their baseline. So he was transfused 10 mils per kilo of red cells. He turned out to have 2 viruses at the same time. He had an IgM to Epstein-Barr virus with IgG positive, and he had a positive parvovirus PCR. And a month later, his hemoglobin is up to 13, his retics are 2.5%, and his absolute retic count is kind of more like his usual, over 100,000. So from the Dr. Smith-Whitley's paper again, they talk about sickle cell complications, and painful episodes were pretty common across the board. So 62% of the total population presented in pain when they had parvovirus. 12% had acute chest syndrome. 19% had acute splenic sequestration. But if you look across the row, if you had hemoglobin SC and parvovirus, there's 50% chance of presenting with acute splenic sequestration. And that kind of makes sense if you think about the spleen being mostly infarcted in the children who have hemoglobin SS or S beta 0 thal. And then most people did have fever at the same time. So we had a couple cases.
I just have a quick question. So did I understand correctly that the parvo and the association with the spleen sequestration, because I would think that it would lead to hypoplasia and the retic count should be low, but in almost all splenic sequestration you would have a high retic count. So what was the retic count in this case?
In the patient that I'm mentioning, their total retic count was 1.9 thousand, so it was very low. So yeah, it wasn't just a pure sequestration. It was sequestration with low retics and a parvovirus PCR positive.
Okay, thank you.
Yeah, and so apparently that's can be seen. All right, the next kid is 11 years old. So also notice that most of the patients are in their early teens. So they're not old enough to have had parvovirus yet, but they're also not the youngest of the kids. And I think COVID probably has something to do with this. If people had not been quarantined for a good, a year, at least a year, maybe they would have gotten their parvovirus at an earlier age than these kids. So this boy is 11 years old and he has hemoglobin SE with a baseline hemoglobin of 10. He had very infrequent sickle cell problems until this illness, when he presented with quite severe pain, and to the point where the team said, he's having a really hard time coping. He's always screaming, and he was kind of felt to have like behavior problems. But and during this pain episode, his hemoglobin dropped from 10 to 8.5. Didn't sound that dramatic, but they went ahead and transfused him because his pain was so severe, and they really didn't know what else to do. So it wasn't until a couple weeks later, when he was kind of bouncing in and out of the hospital, that I noticed during the initial admission that his retic count was also extremely low, and his absolute retic count was 6,000. So he was transfused immediately in the first admission, and his hemoglobin came back up to 10, but he continues to have persistent pain. So this all happened, I think, end of January, and he still has pain, and sometimes requiring treatment with IV ketamine and or IV lidocaine along with PCA or other IV opioids. So eventually he got an MRI showing multiple bone infarcts. And so he did get a chronic transfusion. I'm sorry, he got his first in a series of chronic transfusions a couple of weeks ago, and we're trying to kind of perfuse his bone better. If you can see it, I don't know how big your screens are, but in orange on the top of this graph is his CBC, which shows that his hemoglobin is 10 to 11 typically until 2024 when it did drop down to 8, and then it came back up after transfusion. But what's really interesting is looking at the bottom graph, his retics usually above 100,000, drop down as low as 6.2, 6,000. And then during his recovery from parvovirus, his retic comes back up to over 100,000. So these things kind of go together with his acute illness. The next slide's still about him. So the MRI showed patchy areas of T2 signal abnormality, heterogeneous and prominently in the bones of the pelvis, lumbar spine, and additional focus of signal abnormality in the proximal femur. I wasn't having the easiest time figuring this out, but in the right-hand side in the femur, I think it's the heterogeneous is both the bright enhancement on top of the dark area. So I think that this area in his in the medulla of his femur is probably the infarct. Over here in the vertebra on the left, it's kind of splotchy looking, and I think it's supposed to be more even and homogeneous. And I think that's, and I've seen some pictures from radiology journals where they kind of show this kind of black and white kind of mottled appearance is consistent with bone infarct. So I haven't seen bone infarct from parvovirus per se, but I've definitely seen it in kids who just have severe pain, and it can be very painful and often quite prolonged because it takes a long time for those bones to heal. So all in all, the complications that parvovirus B19 can have in people with sickle cell disease, in addition to the aplastic crisis, can include acute painful episodes, acute chest syndrome, hepatic or splenic sequestration, nephrotic syndrome or other renal disease. I haven't seen it, but they say meningoencephalitis or stroke, and bone marrow necrosis. So those are some things to kind of keep in mind as your patients are recovering from parvovirus, and kind of be screening for some of those as you're going forward. All right. And so here's a little bit of our recent epidemiology. We have the 14-year-old boy with sequestration on December 8th. A week later, we have a 12-year-old boy with hemoglobin SC, also with splenic sequestration, hemoglobin 5.7, and splenomegaly. And the way we learned about this child was unfortunate, because a week before, his 10-year-old sister presented to the emergency room in cardiac arrest and passed away. And her situation is we weren't able to get even a CBC on her because she had no circulation. So her case is being analyzed by the medical examiner. But he was brought in for what they call a wellness check to see how he was doing. And that's on his visit, his hemoglobin was 5.7. So the two of them, well, she probably had the same thing he had. In January, we have the boy with hemoglobin SE and the bone infarcts. And the first case of severe splenic sequestration just happened last week. With a severe hemoglobin of 2, and that's probably one of the lowest hemoglobins I've ever seen.
We had another case at Scottish recently too, that was a 16-year-old with SC and parvovirus who presented with basically multi-organ failure and DIC and a small PE and a subdural hemorrhage, so pretty sick.
Everything, yeah, all the parts. Is that recent, Amy?
Yes, this was a month ago that he presented, and he's actually still in the hospital right now.
I gotta write that one down.
That's super interesting. I'm also interested, what makes you, why'd you get parvo in these patients? Why did you even look for it? Because we certainly see a lot of sequestration in our adults with SC disease, but I can't say that I've ever thought to check parvo.
Well, it's because you know how you get retics every day too, you know?
Yeah.
So the retics were extremely low.
That makes sense.
Yeah.
I have two
So
comments.
yeah, so a typical, you know, typical retic of 4%, I don't really budge, you know, it's like, oh, big deal. But when it gets to less than 1%, then I pay attention.
Yeah, no, that's a fair point. That's why I was wondering if they all had reticulocytopenia, if that's what sort of
Yes.
did you to.
Yeah. That was the clue in.
I have
And
two
you know,
comments
when
to
you
make.
round with the residents and stuff, it's kind of like, okay, you're telling me the retic, so what, right? You know, so when it makes a difference, you do want to act on it.
Sorry, Dr. Raj, go on.
Can you hear me?
Yes.
Okay. I have two comments to make. One is,
Oh, now we can't hear you. We could at first. Or I can't.
can you hear me better now?
Yes.
Okay, so two comments I want to make. One is the increased incidence of parvovirus we might be seeing. Could it be temporarily related to COVID masking and all that we saw in downtrend in respiratory infections, and many of these kids, whether 10 and 11 years old, they may be getting new infections now as they would have gotten much earlier, perhaps, you know. That is one thing to consider. But if you ask me in really Kentucky, what the leading cause of that is,
You keep, Raj, you keep
We,
cutting
yeah,
out.
we lost you in the second half. I heard the first part.
now can you hear me?
Yeah, it's just when you move away, we can't hear you.
Yeah, I'll stay still. So, in Louisville, Kentucky, the leading cause of death in sickle cell disease is parvovirus. In the last 24 years, I've lost 5 children with sickle cell disease. And 2 of them was parvovirus-related acute bone marrow necrosis and systemic fat infarct. And 1 patient died of pulmonary hypertension on the cath table. 1 patient died post-transplant. 1 patient only intestinal transplant infection because of late presentation. So parvovirus is the leading cause of death in Louisville. So we had a lot of research at one time with the researchers. We had a lot of work on parvovirus.
We can't hear you again. You moved away. We heard you through the patients and then you moved away and we couldn't hear you anymore.
Can you hear me now?
A little bit.
A little bit, like the maximum one. Now?
Yeah, I think it's when you look down or move your face that we can't hear you.
Yeah, I don't know, it's so strange. But we had a great researcher doing a lot of work on parvovirus vaccine here in Louisville. The same group that led to the work on Gardasil vaccine, you know, they came to us, I think, from Virginia area that we found and did a lot of good work. But they couldn't get it further because, you know, family problems put that person out of action. But she had a pretty advanced vaccine research. And previous vaccines had shown significant rash and other complications, you know, when they were done on primates. But this was supposed to be a very effective vaccine. But it's unfortunate I can't get her research to move forward. You know, which would be obviously useful in patients with sickle cell disease. Probably can implement. So just those 2 comments about.
Thank you. Any other questions or comments? It's interesting. We had sorry, go on.
Oh, I just have a comment about bone infarcts in that the patients I've seen who have it have severe pain, and it usually leads to healthcare providers just assuming they have behavioral and emotional problems, as opposed to kind of why do they hurt so much, as opposed to they act like they're, they act worse than the average patient. So it's just something to think about when you're seeing patients who have quite severe pain, is to maybe look for bone infarcts.
Yeah, it's certainly the leading cause of chronic pain in our adults.
All right, Dr. Momo here. You said something about parvovirus more common in the younger. Is that correct? Was that what you said? In the younger population?
Well, it's the immunity is higher as you get older because people have been exposed. So I think the not eligible, but the at-risk population is larger among the younger kids who haven't had it yet.
Does make me curious. We had I don't know much because he's a pediatric patient, but a young man who died recently with a cardiac arrest, and I don't know if he never made it to children's, but I would be curious to see if that's something they looked for, because we're not very far away from you. So assuming that you're seeing it, we must be seeing it too, but I don't see Jeff or Chibuzo here, so I'll have to get back to you on that. Last thing, there is CME credit. Please look in the chat. We did add that link, so feel free to click on that if you would like to get that link. And if you get a survey asking you about these echoes, please definitely answer that survey. It helps us keep funding from HRSA, so we want to get as much money, however little that may be, as it could be. And other than that, have a wonderful rest of the week. Stay dry if you're in the Southeast, and I'll look forward to seeing you guys in 2 weeks. Thanks all. Great case, great discussion.
Bye.